Hi everyone, thank you for joining our webinar on Hidradenitis Suppurativa or HS. Our aims for this webinar are to increase awareness of HS among primary healthcare providers, provide practical information about diagnosis and treatment, and elevate the standard of care for HS patients. I'm Naomi Creek and I'm National Coordinator at Global Healthy Living Foundation Australia. Our organisation believes in a world where no patient faces barriers to care, treatment and support, and we are committed to improving the lives of people with chronic conditions and their loved ones. And I've got some great presenters for you today. I'd like to introduce them now. Dr. Monica Narula is a general practitioner with special interests in dermatology and women's health. She's currently a Master of Philosophy candidate in women's health dermatology and holds appointments at the Royal Women's Hospital, the Mercy Hospital for Women, Footscray Hospital, and privately. Dr. Helen Saunders, welcome. She's a dermatologist based in Melbourne. She has subspecialist interests in women's health, vulval disorders, and hidradenitis suppurativa. She holds appointments at St Vincent's Hospital, Melbourne, Bayside Health, and Royal Women's Hospital. And I'd also really like to present Steph Friend, who is founder and director of HS Australia, and she's lived with HS for the past 25 years. Steph is going to kick things off for us to help provide some lived experience of her condition, which will help set the scene for the medical education that the doctors will follow on with. So please enjoy, and if you've got any questions, we'd love to see some in the chat, and we'd also love to know where you're all tuning in from, so please drop that in the chat as well. Please enjoy.
Hi, my name is Steph, and I'm here today to talk about hidradenitis suppurativa. So I started showing symptoms of HS when I was 5. I had itchy bumps on my body in different places, and they would get red and purple and sore and eventually break and ooze and smell and bleed, and it was really awful to not know what was going on. I had to use toilet paper on my arms and anywhere I had the little wounds because I didn't know what they were or how to take care of them. This continued on into high school and adulthood. When I questioned what was happening to me and asked for help, I was given so many different explanations that didn't really make sense. I sat my GP down when I was 30 and had a really brutally honest conversation about how much this was impacting every aspect of my life. They wrote me a referral, and 14 months later, I was able to see a dermatologist. HS impacts every aspect of life, socially, psychologically, emotionally, financially, going to work, studying, relationships, friendships. There is not a piece of your life that HS doesn't touch. So I was really excited to meet the specialist, and they diagnosed me within 5 minutes. 5-minute conversation was all it took about the history of my symptoms. And they said, yep, that's HS. I was diagnosed age 31 after 25 years of waiting. I was relieved. I was ecstatic. I felt hope that my condition had a name. There would be some treatments. I thought there would be a cure, and maybe one day we'll have one. My excitement and joy faded so quickly when I was passed on to the nursing team to look at administering medication. The jokes, the cruel words, the harsh tones. Yeah, I will remember that for the rest of my life. And what was worse was that my specialist didn't want to hear it when I said, hey, this is my experience. It's completely invalidating. They weren't interested. They just brushed it off. And I know I'm not the only one who's had that experience. So I was able to start this organization, HS Australia, to make sure that no one ever felt alone ever again. Part of what we do is educate people. What is HS? How can you treat it? What do we know about HS? because it can take 10 plus years, that's right, 10 plus years from onset of symptoms to diagnosis due to delays through misunderstanding, misdiagnosis. There are a lot of impacts. That's a lot of isolation. That's a lot of awfulness in the world. So we aim to make sure that no person ever feels lonely or disconnected again. We help people have those tough conversations, and our advocacy work extends to the medical field, where we have started working on a wound care program, looking at making changes to MBBS codes for HS treatment, to educating medical professionals as to what HS is and how it impacts patients, and really making sure that our voices are heard. If I could give any healthcare professional, GP, specialist, dermatologist, surgeon, nurse, any healthcare worker, piece of advice, it would be to listen to us, really hear us, believe us, and help us. One of the barriers to care is not getting referred on and having to see multiple GPs to get that referral to a dermatologist. If in doubt, refer your patient out. There is absolutely no harm whatsoever in referring on to someone who may be able to provide diagnosis. We don't expect GPs to know everything about every single medical condition. That's just not feasible. But you are our first port of call. You are the foundation of our healthcare. So we need you to be our advocates. Another point here is that GPs can write referrals for longer than 12 months, which would be incredibly helpful for the chronic illness community, especially when it comes to not having to pay new patient fees every 12 months, which gets expensive. When a patient says, I think I might have HS, or I'm in pain and I have these bumps on my skin, and share their symptoms, don't dismiss them. Don't think the pain isn't real or as bad as you think it could be. I'm here to tell you that it is. 1 in 150 Australians are counting on you to help us. So thank you for taking the time to be here for this presentation. And please feel free to share our name and our resources with your patients, your colleagues, your friends, your social groups. We are here to help, and we want to connect with everyone. Thank you so much.
Thank you so much, Steph, for your comments on HS and sharing a lived experience with us. Welcome, everyone. Today, we'd like to discuss the dermatological condition called Hidradenitis Suppurativa, or HS. As we'll discuss throughout this presentation, HS is a very under-recognised condition that has significant impacts on quality of life. This webinar will therefore focus on how to recognise HS in primary care and factors to consider for our patients. GPs play a very important role in recognising HS early and facilitating referral to dermatology where appropriate, and this is to reduce diagnostic delay and optimise shared care for our patients. Also important is understanding what we know about HS pathogenesis, a brief review of the diagnostic criteria which relate to biologics access, and options for management steps prior to immunomodulating agents. So what is HS? HS is an inflammatory condition, and despite common misconceptions, is not an infective skin condition. It's typically characterised by recurrent, tender nodules and abscesses, and can result in scarring and tunnel formation. Prevalence is estimated to be up to 1.46%, which is likely underestimated due to underdiagnosis. In the same vein, cohort data suggests an average diagnostic delay of 7 to 10 years. There is a female predominance, and those with family history are at greater risk of developing the condition. Importantly, we know that HS causes a significant impact on quality of life. If anyone has any questions, please drop them in the chat below. In terms of dermatology disease impact on life quality, HS is one of the most significant. Patients experience a combined physical and emotional burden of the disease, including the physical toll of unpredictable, painful disease flares and treatment. A 2020 study demonstrated that 97% of HS patients were affected by pain during their disease course, and 85% of people report pain as their most stressful and difficult symptom.
Additionally, the psychological and social impact of the disease, including stigma, is significant. Literature has described a major negative impact on mood, with 1 in 3 people reporting anxiety or depression, whilst 1 in 11 have considered or attempted suicide. Mood effects also flow on to motivation and career. Research also shows a negative impact on intimate relationships, sexual activity, and family planning. And to further set the context, an Australian study from 2022 found that people affected by HS had poorer quality of life scores than those with inflammatory bowel disease, myocardial infarction, and chronic stroke. The pathogenesis underlying HS is incompletely understood, but it's accepted to be an autoinflammatory syndrome that's driven by genetic, hormone, and microbial factors. Importantly, it's not a result of poor hygiene, as patients with HS are sometimes erroneously told. External factors such as smoking and obesity can exacerbate the condition, and there is an association with PCOS, insulin resistance, and inflammatory bowel disease. The pathway underlying the skin changes that we can see in HS are outlined in this diagram, and it begins with follicular occlusion and rupture, which results in an abnormal immune response and inflammatory cascade that leads to the nodules and abscesses. Persistent inflammation can then lead to fibrosis and epithelialized pus-draining tunnels. Presentations to the general practice office can include the complaint of recurrent large pimples, boils or abscesses, painful nodules, itchy inflamed skin, or purulent discharge. And as mentioned, many patients report years of symptoms before diagnosis. Typically, HS affects the axilla, the groin, and inframammary folds. And clues to diagnosis can include lesions that occur in more than one of these body sites or multiple lesions, a chronic course of 6 months or longer, sinus tracts and scarring, and a positive family history. And if there are any GPs who might have had presentations such as these, please feel free to let us know your experience in the comments below. This slide demonstrates some of the clinical findings that might be found in patients with HS. In image A, top left, this demonstrates a solitary, painful, deep-seated and inflamed nodule which can signal the start of HS. Some patients experience a prodrome, and that can include fatigue, localized itch, or even paresthesia. The development of multiple recurrent inflammatory nodules within a limited area of the body can predispose the patient to form intercommunicating sinuses, shown in image B. Patients with sinus tracts often experience intermittent release of blood-stained, seropurulent, and malodorous discharge. Erosions and ulcerations can also occur, as well as post-inflammatory hyperpigmentation, more commonly seen in darker skin tones, as shown in image C. Closed comedones are frequently seen in HS due to the follicular occlusion, and double-ended pseudocomedones are frequent, shown in image D and the figure on the right. Long affected skin can appear as pitted hypertrophic scars, fibrotic bands, and indurated thick plaques that affect an entire anatomical area, as seen in images E and F. I'll now hand over to my colleague, dermatologist, Dr. Helen Saunders.
So thank you very much, Monica. So far we've seen that HS is typically a long-term or chronic condition. It presents with very painful boil-like lumps, and these can be under the skin or they can leak pus, and they frequently cause scarring. And this commonly occurs in the axillae, groin, genital and submammary zones. The pathogenesis is emerging, but importantly, it's an auto-inflammatory condition associated with follicular occlusion and subsequent immune dysfunction. If there are any patients who are listening to this, we'd be very grateful if you could make some comments. We'd love to hear from you about your journey and what you've found helpful and unhelpful. So how do we confirm that someone is living with HS Unfortunately, there is no diagnostic test or biopsy feature which helps, so we do rely on a clinical diagnosis. At the moment, the internationally recognised standard is known as the Dassault criteria, after the town in Germany where the first HS International Research Symposium was held in the early 2000s. And there are 3 diagnostic pillars to this criteria. The first involves morphology or a typical lesion. So in early disease, that might be a nodule, so something which is deep-seated and painful, and the patient may describe as being like a blind boil. It may also be an abscess, which is something which is fluctuant, or later a tunnel or black spots, which look like blackheads or open comedones. The second diagnostic pillar is the location, so the site where these lesions are occurring, and generally that will be in the skin folds where the apocrine glands are present. The third pillar is the evolution or the time frame, and generally this disease will be relapsing and remitting, and the formal diagnostic criteria is to have had 2 episodes in a 6-month period. Supporting the diagnosis would be some other features, including a positive family history. So we know that around 1/3 of people living with HS will have a first-degree relative who has HS. The lesions will typically be sterile. So if we were to culture a primary unruptured lesion, this would be sterile or show skin flora only. And there are strong associations with comorbidities, including obesity and overweight, smoking, and metabolic syndrome. So there are a number of mimics for HS. The first one is simple furunculosis. So this is essentially a bacterial infection, usually with Staph aureus, affecting the hair follicles. Acne conglobata is a rare and severe form of inflammatory nodulocystic acne. Pilonidal sinuses typically would be a tunnel-like lesion in the nasal cleft. And Crohn's disease is something that we think about, particularly when you have disease that's affecting in the underwear only, and when it's prominent around the perianal skin with involvement of tunnels or fistulae. So cutaneous Crohn's is certainly an important thing to consider. So disease severity is something that we have to think about, and this is a way of objectively quantifying a person's condition. But we must always remember that what could be classified as mild disease may still have significant impacts, particularly with pain, as we've mentioned previously. The original scoring system used is the Hurley system, which you can see there with the pictures, and the formal diagnosis there is in the purple box. And essentially, it's a way of separating mild disease from severe disease, which you'll see there where you have scarring affecting a whole zone. It's a fairly static measure, but is one that is quite useful. In contrast, we sometimes use an AN count, which can be used to track inflammation and disease severity. This score is the foundation for a measure which is frequently used in research, but also in accessing PBS-funded medications for HS in Australia. If you have specific questions about HS, please leave them in the comments. So the principles of management of HS are quite complex, and this really is a disease where holistic, patient-centred approach is key. Importantly, there is no one-size-fits-all medical model, and you really need to develop a strategy in partnership with the patient. Please bear in mind that most people with HS have been living with this for a long time and often will have much better knowledge of their condition, the triggers and tricks that work for them than you will. These people will often have had multiple poor interactions with healthcare services, and if they have trusted you enough to come to you about this issue, please proceed with sensitivity, genuine curiosity and care. You must use a culture of safety. It's important to ask open-ended questions, to practice active listening, to use gender-neutral language where appropriate, and to conduct your examination in a trauma-informed manner. So there are a number of lifestyle and supportive measures which can have a positive impact
on HS. Evidence suggests that smoking cessation and weight loss can increase the efficacy of systemic medical agents, as well as having overall health benefits. As we've mentioned previously, pain control is very important, and this is often the predominant symptom which really impacts people's quality of life. And depression and anxiety are extremely common and under-recognised. There are a number of resources available in Australia which are here on the screen for you. There's an excellent booklet from HS Australia, as well as an information sheet from the University of Queensland. These are some published guidelines on the management of HS which can help, but obviously they're quite complex and a little bit cumbersome. And essentially you would pick from this the bits that would fit with the person with HS that you are dealing with. The purple box down the bottom is an important box which deals with how you manage a flare. So a flare will typically be a nodule or an abscess which has become inflamed and is quite painful. So options for treating this would include some intralesional topical steroid. If the lesion is very tense and extremely painful, you may do incision and drainage, but please bear in mind that this is really only for symptom management and it will not resolve that lesion. The recurrence rate is 100% from incision and drainage. Other options in very rare circumstances would be a short course of prednisolone, and if the lesion is genuinely secondarily infected, you might consider a course of oral antibiotics. When someone has mild to moderate disease and you are considering that some form of suppressive therapy is needed, there are a number of options. Topical clindamycin is something which was studied early on with HS. However, there is some thought that we should be moving away from this with the emergence of resistance and antibiotic stewardship, so probably other antiseptics are as useful as topical clindamycin. Oral antibiotics are generally used for their anti-inflammatory effect rather than for infection, and typically a tetracycline-based antibiotic could be prescribed for a 3 to 6 month course. In female subtype who have a premenstrual flare, hormonal treatment can be effective and useful. This might include an anti-androgen oral contraceptive pill or an anti-androgen agent such as spironolactone. Surgery can also be useful, particularly when there is a problematic lesion or area which has not responded to general or medical measures. There's a particular form of surgery called de-roofing, which is practiced now and it has a much lower risk of recurrence. In moderate to severe disease, so those people with early stage 2 or 3 who have more than 4 nodules and who have failed standard suppressive therapy, we do now have the availability of a number of advanced or biologic therapies. These are prescribed by dermatologists on the PBS system in Australia. There are currently 3 listed therapies, and unfortunately there are no head-to-head trials to help us with which of these is likely to be more successful. But the current listed drugs include an anti-TNF agent, an anti-IL-17 agent, and more recently a combined anti-IL-17A and F agent. However, this is an extremely rapidly evolving field and there are a number of agents currently in clinical trials, and these are certainly available to people who are finding standard therapy is not working for them. At present, there are no validated screening tests which have been recommended, so a patient-directed approach is best, but I would highlight to you that mental health disorders, particularly anxiety, depression and suicide risks, are very high amongst the people with HS, as are metabolic complications such as dyslipidemia, hypertension, metabolic syndrome and polycystic ovarian syndrome. Increasingly, we're becoming aware that there is a window of opportunity to treat people, and we really want to try and get in prior to them developing severe disease with sequelae including scarring and tunnels. So early recognition and education is very important, and referral where appropriate. There are a number of rare complications including SCC, but this is quite uncommon, fortunately. So the key messages that we would like you to take away today is that HS is a common, underdiagnosed autoinflammatory condition which has significant negative impact on quality of life. There are many significant comorbidities which are important to address. There is a window of opportunity, and it's important to try and treat early to prevent scarring and tunnel formation. So we hope today that you've now feeling more comfortable with how HS might present. You're aware that the core pathogenesis is auto-inflammatory rather than infective. You're aware that the diagnosis is clinical and that a holistic patient-centred approach is needed to treatment. Thank you very much.
Oh, thank you, Monica and Helen and Steph, for such a great webinar.
Thank you for having us.
No problem. We hope everyone's enjoyed watching this. If you'd like to receive some education and support resources for your HS patients, please drop us a line at info@ghlf.org.au. See you next time.